Welcome to Behavioral Health Champions, where we have an opportunity to engage with members of California's legislature on the critical issue of behavioral health. And in this case, as we've all been talking about, how do we make certain that we have parity for behavioral health care services? I'm Carmela Coyle. I serve as the president and CEO of the California Hospital Association, and I'm joined by Jessica Cruz, who leads the National Association of Mental Illness for California, NAMI California. And we are very pleased today that we are joined by Senator Richard Pan, Dr. Pan, in what will be a very important conversation for us.
So thank you so much for taking the time. We're with Dr. Richard Pan, who is the chair of the Senate Health Committee and represents the 6th District, which is the Sacramento region. Thank you so much for taking the time.
Well, thank you. Thank you for having me here.
So what an important opportunity for us, and what a unique member of the legislature that you are as a physician. Could you talk a little bit about what got you interested in the medical field?
Well, actually, growing up, I saw how doctors worked with patients and also involved in science. I admit that my first interest in medicine was when I was fairly young. I was in 3rd grade and I read a book about blood, and I thought blood was really cool and all the different blood cells, and thought, well, who gets to study and about blood? And said, well, doctors do. And so that's sort of my first interest in medicine. I also had some relatives in medicine as well. And so my initial goal in medicine was to focus on discovering the next great cure, medical science. I was a biophysics major in college and really looking at sort of the molecular biology of things, study DNA structures, histone structures. But then I also got pulled into looking at issues around populations and health, and really thinking about, even when someone develops the next great cure, it doesn't help anyone unless people have access to it. And so I like to talk about, I went from the micro to the macro and got more involved in looking at populations and social determinants of health. In fact, got my master's in public health as part of my training, as well as my MD. Entered into pediatrics. I'm a pediatrician, but also actually, interestingly enough, focused on particularly developmental pediatrics. So I was a general pediatric fellow with a research focus on health services research, quality, social determinants of health, but clinically did additional training in behavior and development before it was formally a subspecialty. So, and in fact, as a general pediatrician, I still primarily took care of kids when I was at UC Davis who had behavioral issues, learning disabilities, and so forth. So behavioral health was certainly a very important part of my practice, and something that was very important to me personally as well.
That is such an interesting background. I mean, just from when you were growing up and how each step kind of led you to something bigger and better, like opening another door. How did you walk through that door to get into politics and the policy?
Well, so I came to UC Davis in order to try to teach pediatric residents, future pediatricians, about social determinants of health, about how the Community Impacted Health started a program doing that. Talked about how doctors need to be involved with community groups, get out of the clinic, get out of the hospital, partner with community groups, support them in trying to improve health. Now, if you're trying to teach students this, you have to model that as well. You can't just tell your students, go and do this, and they go look at you and say, you're the professor, so what do you do? So, of course, I had to do it myself as well. So I was active in the Medical Association, got on the First 5 Commission, worked on many issues there. Actually still serve on the United Way board, where we do various projects to help people, both children and others as well. And actually, as I got more involved in these different activities, also saw how important government was in playing that role, right? If we're talking about social determinants of health, we're talking about built environment, we're talking about traffic, we're talking about supports for families, access to health care, particularly for people who are low income and may not get it through their job or can't afford it. Actually was chair of our Children's Health Initiative, so we got 5 counties together. We provided health care to children who would not qualify for Medi-Cal, who are still low income, helped 65,000 families, 65,000 children get health care for their kids. Got funded by foundations and other groups as well. So the hospital systems were very involved in that. So those are some of the things I was doing in the community. But during the Great Recession, saw that people, I was frustrated with state government. They couldn't pass a budget on time. I saw what was happening in the community, and finally thought to myself, well, if I'm not willing to put my hat in the ring to run, how can I complain about what's going on? So never held public office before, was kind of in the wrong district for my party, I'll just put it that way. But ran for office and won, telling people like, I'm running to try to solve problems. Here's my past record in doing that. And so that's how I ended up in the legislature.
That's fantastic.
That's wonderful.
Well, let's start with the great divide. The challenge in this issue that we tend to treat diseases of the body differently than we treat diseases of the brain. We treat physical health differently than we treat behavioral health. Could you talk about your views of some of the issues and challenges related to behavioral health that we face here in California?
Well, you're right. We do tend to think about mental health as separate from physical health, which is completely untrue, right? And this goes back to all the way back to the Greeks in terms of how people viewed mind body as being separate, right? And but that's actually just not unique to, I think, Western culture as well. And fortunately, the brain is an organ. It's an organ of the body. It's supported by the body, and so when you have problems with the function of the brain, you develop symptoms, and there should be equal treatment, but unfortunately there's often shame attached to that, right? And there's a different cultural context, and we need to recognize that, because that affects both the patient, the people who surround the patient, and hopefully will be supportive but may not be, and then it also affects public policy as well. And so we need to remove the stigma. We need to allow people to speak more openly about it. We also need to tell people that we need to help support and provide access to care. And actually the other thing is that we need to remind people these are treatable conditions. Too often people say, oh, it's a mental health condition, therefore it may not be treatable. And that's not true. We have very successful treatments for that. So, and by the way, there are many physical health elements that are very difficult to treat too, but yet we are willing to put the resources and the effort into helping those patients. That should be equally true of people with mental health issues.
Great. And so in your role as the chair of the Senate Health Committee, do you feel that we as California are doing a good job of addressing behavioral health issues?
We could do much better. So part of it is this divide, which we've actually is reflected in the way we support mental health. So in our Medi-Cal program, we actually have mental health, mild mental health is supposedly integrated into the managed care plan that takes care of the rest of the health, but severe is a separate plan. We have separate mental health networks, which isn't necessarily bad in itself, because if you have severe, you need them. And we have other specialty networks as well, but the level of integration that happens could be improved. Even in our commercial plans as well, we often have mental health may be carved out, and so there's a lack of integration. And then the way we organize our health systems, right? So, you go to the emergency room, and we actually have had several bills this year about, how do people show up in the emergency room, but they don't have the capacity to take care of them. How do we get them to a mental health facility? But because not every hospital, actually, probably not a whole lot of hospitals have psychiatric facilities within the hospital itself. So now they have to be transferred to an outside facility, which then says, psychiatric facility says, well, we can't take care of the physical health part, so if there's any physical health issues, we're nervous about taking them, right? So we have this divide we have in the way we structure things. We have a divide in the coverage. And then the other thing I also want to speak about is that mental health, as I said, is treatable, but it is it's pretty much generally a chronic condition. We have not invented cures for most of our mental health conditions. These are chronic conditions, kind of like asthma or emphysema or other physical chronic conditions. And our healthcare system and the way we finance it is actually challenged in terms of actually supporting people's chronic conditions. In fact, when we implemented the Affordable Care Act, we put some very important reforms, including not denying people for pre-existing conditions. Pre-existing conditions are essentially chronic conditions. A pre-existing condition is a condition you still have when you have to sign up for your insurance again, right? That's really what it is. And so we need to really think about how we structure our financing system in a way that encourages people to actually want to take care of people with chronic health issues, and then promotes innovation in that as well. So I'm a strong supporter for mental health parity. That's very important. But I've always said parity is not enough. Parity is not enough because even when we have parity, if we don't also figure out how we incentivize care of chronic conditions, and that in my mind includes mental health. Sometimes people say chronic conditions, they don't mean mental health, but I think that includes mental health. And we create those kind of incentives, then people still are going to have challenges getting care. And so we have to have those incentives. How do I know health reform works? Well, if I see health plans advertising, if you have a mental health issue, come join my plan, then that means we've been successful.
Yeah. Well, let me pick up there. Jessica and I often, in our role leading the Behavioral Health Action Coalition, are talking about the challenges of we are able to treat people when they have an acute episode, when they're in crisis. But there is often no place out in the community, the system. We don't have the full continuum of care. One of our top priorities is prevention and early intervention. How do we prevent people from falling into crisis? From your perspective, both in the legislature and as a clinician, could you talk a little bit about the importance of prevention and early intervention and perhaps some of the challenges associated with that?
Well, certainly as a pediatrician, I understand how important prevention and early intervention are. And so one of the things that I've been working on actually here in the legislature is to increase access to mental health for students who are in higher education and also K through 12 education. So I have some specific bills around those issues for higher education. I've also worked hard to try to increase access to mental health services in schools as well. And so we can better detect and actually try to provide intervention as well. In fact, I have a bill this year to train teachers and other staff in schools to provide essentially what we call mental health first aid to identify people. But I also want to recognize that while we can train teachers and staff to identify and also maybe do some initial intervention, it's like teaching someone CPR, right? If there isn't a system to back them up, someone can only do CPR for so long and the person's still not going to do well, right? Right. So the first thing in CPR is like call 911. There needs to be backup. There needs to be the system there, right? Because so we need to put that in place. But also to go back to what I said about mental health as a sort of chronic condition and the need for ongoing treatment. So one of the fundamental issues we do have in our healthcare system is that what happens is that when someone has an acute episode of something, right? You have diabetes and you develop PKA and you crash. You show up in the emergency room. We put a lot of resources in there, right? You go to the ICU and so forth. And then when everything's fine, we send you out and we don't give you a lot of support. We're seeing the same thing in mental health, right? So what happens is that when someone's suicidal or this 5150, etc., you show up, we get you, and then when we send you out, do we do the follow through? And it's very expensive to just do like crash and burn medicine. That's what I call it, right? So basically, when you crash and burn, we all dive in, and then when that's over, we put out the fire. Maybe what we should do is focus on keeping you healthy. So when you say prevention is both about what do we do in the front end? So addressing many of the things that can acutely trigger mental health issues like depression, other types of things. But then we also have to recognize we need to provide ongoing care. Yeah. People have schizophrenia, they have bipolar, etc. They can lead full, productive lives, but we need to provide ongoing care instead of saying that. Well, what happens is we'll try to catch you when you crash.
Yes.
Try, by the way, not always.
Right.
And right, so we need to think about that and how do we integrate this together. Now, again, we have a lot of things that we have to work on because we've structured our whole financing system. We've structured the way we organize our healthcare system in ways that don't facilitate that. But for example, as a pediatrician, I know that talking to many of my colleagues as well as in my own practice, I know that mental health issues are very common and we see them frequently. And so do we better integrate physical health and mental health? How do we train our primary care doctors? So I train general pediatricians to do that. And then how do we provide supports as well, so that when people are trying to take care of them, they're not, and they need more help, that they can get that. So there's been many different models that we can look at. I was proud to actually hold a town hall that was sponsored by the Steinberg Institute, looking at innovations in mental health that have been done around the world. And actually I think there are some there's been some legislation written around, but we do need to think about how we structure this. I'm really excited that Governor Newsom has found someone to be a mental health director who is interested in looking at innovation as well. I'm looking forward to working with him and the governor's office around this. And this is really going to be something that not only, of course, most importantly, we want to improve outcomes, we want to improve people's lives, but also I think we'll actually also improve our bottom line in terms of budget as well. We should make more cost-effective use of our dollars.
Behavioral health care, if we can get it better, or even will make care more affordable for everybody.
Right.
Yeah,
well, as I pointed out in a recent press conference with the governor, California is actually reducing the cost of healthcare. We're getting more people covered.
Yes.
Some people think that's a little backwards. No, it isn't. Actually, getting more people covered, because I try to remind people that lack of care doesn't cause people to stop being ill. It may hide it a little bit because you may not see, but eventually they will show up. So everyone who has a mental health condition, it will manifest and it will eventually require care. Now, they may not get it, but we will see the effects of that, not only on that individual, but also on the community at large. And that's the cost that we don't often talk about. We talk, if we have to provide services to this person who doesn't have it, it's, we can tally up the cost, et cetera. What we aren't so good at is tallying up the cost of, if we don't do anything, what's the cost we pay there? And there is a cost. It's a little harder to attribute specifically, but there's a cost to that. And it's not all about, so I know I'm talking dollars, so there's a dollar and cents cost, and then there's actually a societal cost and a moral cost even.
And kind of piggybacking on that, families are kind of at the nucleus of being the care provider for their loved ones. 99% of the time, our loved ones are at home.
Right.
And so can you talk and tell us a little bit about how families, especially in unserved and underserved populations, can access help, or how they could be, how they can maybe navigate the system better to get their loved one the help they need, and also to care for themselves?
Yeah. So one of the things we do also need to work with is trying to make the system a little simpler. You just use the term navigate, right? And actually it's interesting because we often talk about how we need navigators for families, and because our systems are so complicated and difficult to understand. And even people who are very sophisticated and highly educated have difficulty navigating the system. And so we need to do a better job about trying to figure out how do we make it simpler for people to access the care. In the back end, we can figure out all the complications, but for patients, how it can make it easier for them to get the care they need, make it more straightforward when they need help. Because ultimately, in the end, what happens is that, if they can't figure it out, eventually what happens is that the bottom line is someone may end up having picked them on the street, usually our first responders, and then they come to the emergency room. And then we're trying to sort it out there, right? So, that's, again, the cost of not doing anything. So we do need to think about how we build better systems of care. So when we talk about, for example, how we better integrate mental health with primary care, right? And so that, of course, we need to be sure the primary care is accessible, but how do we better integrate that? How do we provide, let's say, point of care support to primary care doctors, right? So primary care doctors do have some training in mental health as someone who is a medical educator, but remember, just like I said with the teachers, but we need to be sure that they can get some additional support when it gets beyond their comfort level, right? So we need to be able to pass that on. But oftentimes they can help triage. So for example, there was a model in Massachusetts where I did my training, where actually child psychiatrists would be essentially on call for primary care doctors. So notice, instead of making a referral to a child psychiatrist, a pediatrician could actually call, and I think they even tried to set up a thing where they could do a Skype interview with the patient to do an immediate consultation at the time, so that way when the patient's still in the exam room,
Yes.
the doctor can then actually say, well, I'm not sure what to do. Okay, let me talk to the child psychiatrist. It's not like I write a letter referral and, why don't you go home, and when I find out what to do, I'll call you and tell you, or you come back, right? You know how well that works. So they could actually say, let me talk to them and say, okay, well, these are the things we can do now. The person may or may not need a referral. This would be the follow-up, et cetera, so they can get that support and guidance, right? So how do we provide those kind of support so we can better integrate, right? And also, in some ways, actually make more efficient use of our mental health professionals, which we do have a shortage of.
Right.
So full disclosure, my brother's a child psychiatrist, so
great.
it's so I know how important mental health is, and actually how few psychiatrists we have, and also other psychologists and so forth. We often talk about our mental health workforce. So how do we actually build that workforce so we can build that capacity, but at the same time make the most effective use of that workforce as well? And how do we be sure we also leverage our primary care folks as well, recognizing we also have a shortage of them. But again, these are surmountable. We can do it, but we can certainly think about how we better integrate our care and provide those kind of support so we can make most effective use of our resources.
Great.
So I wonder, we only have a moment left,
Okay.
but perhaps in closing, it's certainly Jessica and I together, and for the coalition that we represent, we feel like we're at a moment here in the state of California.
Yeah.
You've mentioned the governor,
Right.
his keen interest in this issue,
Yes.
appointing a mental health czar, Tom Insel, who is terrific. We've got behavioral health champions like yourself. Could you talk just a little bit in closing about how we maintain that momentum and how we can continue to work together to really create change here in this state?
So I think one of the things we're going to need to do is to step back a bit and say, how should we better organize and finance our mental health system in a way that can better serve our patients? We've evolved over time for various different reasons, some good, right, reasons to what we evolved today. But we have a tremendous amount of fragmentation. We have fragmentation, we already talked about, between physical and mental health, how we bring those together. We have fragmentation in terms of different sites, because I'm a pediatrician, I work with schools. You have schools, and you have county mental health, right? Where does that come together? And then we even have fragmentation between different levels of government.
Exactly.
So it was great to have a mental health czar at the state to provide leadership. But as I was doing that town hall talking about, for example, the state of New York, and I kept thinking, well, we need to figure out how, between the county and the state, and how does that come together? And then, of course, when we talk about social determinants of health, right, we have to think about, we have people who have mental health conditions, we provide them treatment, but also we need to help think about how do we create a healthier environment for them,
Yes.
right? So a person without housing, we can provide them all of the therapy and medications and everything else, but the stressors are way too high, right? That's not gonna work. If someone who doesn't have, variety of different things, right? You talk about families. Well, what kind of support does the family have? What family is there for them, right? So, what other supports? So things like that. So, how we pull that together as well. But I think we really do need to think about. Certainly, mental health is a high priority. I know for many of my colleagues in the Senate, when we had a gathering, we talked about. I know that it's an issue that for my local elected officials and local governments here, as they're trying to struggle with how to deal with a variety of different issues, and certainly know it's a priority for the governor. So we need to take this recognition and this interest, and say, how do we come together and say, you know what, over time we've evolved these different things, and everyone has a certain stake in them, and they've came out for different reasons. Some of them have said good, right? But how do we say, okay, you know what though, we have the Prop 63 funds over here, we have Medi-Cal, let's not underestimate the Medi-Cal piece of it, right? We have, how should we reorganize some of these things so they can better serve patients, right? And simplify things for them, better allow things to connect better. How do we try to break down the fragmentation? Because that fragmentation causes all sorts of problems for patients. It creates inefficiencies. It makes it difficult for people to get care. Sometimes it also becomes an excuse not to provide care. Oh, it's not my piece, someone else, etc. Let's figure out how to bridge that, and let's look around at different models and think about how do we make it, how do we really improve that. So I'm really looking forward to having leadership and administration around that. Certainly through the legislature, I'm very interested in working with Dr. Insel and the governor to say what are we going to do to pull together. I'm very interested in working with other behavioral health directors, right?
Yes.
How we pull everyone together, and certainly advocacy groups, right? Like NAMI. NAMI is very important. I'm proud to support NAMI in a variety of activities in my district. Your voice is so important. We need to be sure that consumer voice is there, and of course the rest of the health system as well, right? The hospitals, right? You're showing up in your emergency rooms, right? Is what's the best? How do we do it? We need to work with our first responders who are out in the field, right? What are we going to do? So, what do we do with the different providers, mental health and otherwise? How do we pull people together? So I think there's an opportunity to do that, but I think that opportunity is going to be best realized if people are willing to say, okay, just because we've done it this way for a long time, is that necessarily the best way to do it?
Yeah. Well, on behalf of the Behavioral Health Action Coalition, we thank you for your expertise. We thank you for your passion. We thank you for your leadership and for being one of Californians' behavioral health champions.
Well,
we really appreciate it.
Thank you so much.
Thank you very much.
Thank
Thank
you.
you. Thank you
Thank
very
you.
much. Thank
We
you.
appreciate
Thank you.
it.
Thank you so much.